All right, so we're going to finish up a little bit on the spinal cord here, just pointing out the pathways. Most of this will look the same at about every level, but there'll be a few unique things, and I'll point those out as we go through. So let's first consider sensory information that's coming in through the dorsal root. Remember, we have large myelinated fibers here that convey vibration and proprioception. We have small unmyelinated fibers that convey pain and temperature. So for vibration and proprioception, these fibers come in to the posterior columns here. There's no synapse, no crossing, and they ascend all the way up into the lower medulla. That's where we get our first synapse. And so below T6, arbitrarily, we just call this the fasciculus gracilis. Once we get above T6, then we will see these fibers in the lateral portion here begin to enter, and we will call these fasciculus gracilis. Essentially, you need to associate the fasciculus gracilis with vibration proprioception for the leg, and fasciculus cuneatus with vibration and proprioception for the arm, because the thoracic areas are, not so important in terms of those sensory modalities. All right, pain and temperature comes in, ascends for a segment or two in Lissauer's tract. And unlike vibration proprioception, we have a synapse here. And this nucleus is called the substantia gelatinosa. It's in layer 2 of the dorsal horn of the spinal cord. And after the synapse, it moves out and crosses over as the ventral white commissure, and then ascends about out in this location. I have it labeled over here as the spinothalamic tract. Okay, so very important, two big distinctions here. Pain and temperature. We have a synapse in the spinal cord, and it crosses in the spinal cord. Cortical spinal tract is out in this location. There isn't much of it here at S2. And I mentioned the spinothalamic tract. Notice that out here in the very lateral portion of the white matter, we have only the ventral spinocerebellar tract at this level. Okay, and that is because the fibers that will become the dorsal spinocerebellar tract, and we'll see this come in later, they are actually traveling up through the posterior column. And they do that all the way until we get up to L2, and then they begin to synapse in this area of the spinal cord as Clark's nucleus. But until that happens at L2, we don't have any dorsal spinocerebellar tract out here. Okay, in this location, we have the medial motor system. So recall that these are upper motor neuron pathways that for the most part supply axial midline muscles like the vestibulospinal tract and the reticulospinal tract, compared to the lateral motor system out here. So most of this is cortical spinal tract, but the rubrospinal tract is another upper motor neuron pathway that travels out in this location. All right, anterior horn cells, which are the lower motor neurons in the spinal cord, are in this location, and we can see the ventral root fibers exiting here. So again, these are lower motor neurons. A lesion here would produce lower motor neuron findings at this level. Now this is L2, and so most everything is the same, but remember from T1 to L2, we have two unique things that happen. First, we have out here a nuclear group, and this is called the intermediolateral cell column. All right, and these are preganglionic sympathetic fibers. They're from T1 to L2, and they're in this location. They'll be more obvious. They'll stand out a little better when we get up to the thoracic cord. The other thing that is unique here is Clark's nucleus from T1 to L2. So again, this is information that's destined for your cerebellum. And so it hitchhikes here with the posterior columns, synapses in Clark's nucleus, and then moves out into this location. So now we have the dorsal spinocerebellar tract once we get up to L2 level of the spinal cord. So we have dorsal and ventral spinocerebellar tracts. Here I have it labeled over here, ventral and dorsal. Okay, everything else is the same, fasciculus gracilis. So again, if you were asked a lesion here would result in which of the following, the right answer would be a loss of vibration and proprioception in the ipsilateral leg, right? Because the pathway hasn't crossed yet. Whereas if you were asked what would happen with a lesion here, well, remember the spinothalamic tract, this pathway originated through the ventral white commissure, substantia gelatinosa, dorsal root. So a lesion of the spinothalamic tract would produce loss of pain and temperature on the opposite side of the body, below the level of the lesion. All right, with a lesion of the cortical spinal tract, so again, remember where this comes from. It's the opposite hemisphere of the brain, crosses in the medulla, and then descends here in this portion of the spinal cord. So a lesion here would produce ipsilateral weakness below the level of the lesion. And of course, this is a very important upper motor neuron pathway, so we'd have upper motor neuron findings. Okay, lots of anterior horn cells here. And since we're at L2, we can kind of imagine what clinical deficit might happen with the lesion here. From our lecture on roots and plexus, remember that L2, 3, 4 anterior horn cells supply proximal muscles in the leg, the quadriceps, the thigh adductors, iliacus for hip flexion. Okay, so if we had some process here knocking out these anterior horn cells, a patient would have weakness of those muscles, atrophy of those muscles, the patellar reflex would be absent, so we would have lower motor neuron findings. All right, now the thoracic cord is very distinctive because we have very few anterior horn cells, because we only have some intercostal muscles here. Okay, so we don't need a big ventral horn. We can still see our intermediolateral cell column, much more obvious here for preganglionic sympathetics. And in this location and labeled over here, we have Clark's nucleus. Okay, so again, Clark's nucleus, I'm going to associate that with the dorsal spinocerebellar tract. So we have dorsal, ventral spinocerebellar tracts, and still cortical spinal tract and spinothalamic tract here in these locations. Now, since we're at T6, we begin to see just a little bit of the fasciculus cuneatus. Okay, and so the columnar arrangement here of these pathways is important. Notice that for the posterior columns, our sacral and lumbar and thoracic below T6 are in this medial location, and as we move up into the cervical cord, we have the upper thoracic and cervical cord out in this lateral location. Okay, the columnar arrangement for the cortical spinal tract and the spinothalamic tract is exactly the opposite. Here we have the sacral fibers lateral, and then lumbar, and then thoracic, and then cervical once we get up there. Okay, this actually does have some clinical significance. Next year we'll talk about compressive lesions of the spinal cord. And with respect to these motor and sensory pathways, since the sacral fibers are lateral, those tend to be involved earlier than the more medial fibers, which might be somewhat more protected. Okay, so again, for pain and temperature, ascends in Lissauer's tracts, synapses in substantia gelatinosa, crosses over as the ventral white commissure, ascends as the spinothalamic tract. All right, now we're at C8 of the spinal cord, and so a huge ventral horn. Okay, why is it so large? Well, think of all the C8 muscles we talked about in the root and plexus lecture. So these are all median, ulnar, radial hand muscles. All right, so if we had a lesion here, then we would have weakness and atrophy of those muscles, maybe fasciculations. Okay, so we'd have lots of lower motor neuron findings. We can see the nerve roots exiting here. All right, but out lateral, we still see the cortical spinal tract, spinothalamic tract, dorsal and ventral spinocerebellar tract, still our dorsal nerve root, Lissauer's tract, substantia gelatinosa, ventral white commissure, and then again moving out here to the spinothalamic tract. Let me just say one thing about the ventral white commissure. We will talk next year about a central lesion of the spinal cord. Okay, this is called syringomyelia. And as this cavity develops in the center of the spinal cord, the first thing that's involved are the crossing fibers here for pain and temperature in the ventral white commissure. So what this produces then, since these are fibers coming from this direction and from this direction, is that you get a perfectly symmetrical loss of pain and temperature. In this case, it's at C8. That's the level we're looking at. And so you'd have decreased pain and temperature in a C8 dermatome in both arms. So remember, the fifth digit is C8, so it would be extending down to the fifth digit. Okay, so more on that later, but just anatomically, a lesion right there would produce symmetrical loss of pain and temperature. Now at C8, we've got a lot of the fasciculus cuneatus. Okay, again for the arm, and fasciculus gracilis for the leg. The medial motor system here, remember a lot of this pathway just goes to cervical anterior horn cells. Okay, so it'll synapse on these anterior horn cells, like the tectospinal tract. All right, so remember that allows you to turn your head to an auditory or a visual stimulus. All right, so it just goes to cervical anterior horn cells. And the other one we mentioned is the medial vestibulospinal tract, and that's the one that moves your neck appropriately in response to head movement. Maybe you're falling and you make a corrective movement. That's the medial vestibulospinal tract. All right, so we talked about that last time, but I'll just point it out that it would be in this location. Okay, so highest yield of all, certainly for step one, I think, as it relates to the spinal cord in terms of a clinical syndrome, is the Brown-Séquard syndrome. And so three key pathways here that are part of Brown-Séquard. First, we have the cortical spinal tract, which crosses in the lower medulla and descends on the opposite side of the spinal cord to communicate with anterior horn cells via an interneuron. So these are our lower motor neurons here. So if we have a lesion, let's say of the left cervical cord, the patient will have spastic weakness below the level of the lesion. Upper motor neuron findings like clonus, Babinski sign, below the level of the lesion. Okay, if we look here at the posterior columns, so let's say this is fasciculus gracilis for the leg, fasciculus cuneatus for the arm, and again we put our lesion in the left cervical cord. Since this hasn't crossed yet, okay, it doesn't cross until the lower medulla, we're going to have a loss of vibration and proprioception that is ipsilateral below the level of the lesion. So the key thing with Brown-Séquard syndrome is just to remember that pain and temperature enters, ascends in Lissauer's tract, here's substantia gelatinosa, and it crosses in the spinal cord. Okay, so a lesion in the left cervical cord will produce a loss of pain and temperature on the opposite side of the body. Now remember, these are coming in at every level. So we've got millions of these entering all the way down. So if we destroy the pathway right here, we lose out on all of the pain and temperature below the level of the lesion. Okay, so it's the contralateral arm and leg that would have the loss of pain and temperature. Make sure you remember that. Okay, and our last section here is C2, which is very high, and it looks a little confusing. You might think this is thoracic cord, but that's just because very few anterior horn cells here. Most of this is the spinal accessory nucleus, which is 11 to supply the trapezius and the sternocleidomastoid. The other thing that's confusing is there's a pathway here. And this is actually the cortical spinal tract. The reason it's in this location is because the medullary pyramids just crossed. Remember, the medullary pyramids are midline. And so this pathway is moving out into this more familiar location. Okay, if we were to go down to C3, we'd see it out there. But at this very high cervical level, it's still moving from medial to lateral. Everything else is the same. Dorsal, ventral spinocerebellar tracts, spinothalamic tract, Lissauer's tract, substantia gelatinosa, ventral white commissure, and the fasciculus gracilis and cuneatus here. All right, so we'll stop there.